Hello, listeners. The following presentation, PowerPoint presentation, is about addiction and specifically a treatment case study that we worked on through Class 585, which is Substance Abuse and Addictions, at the Chicago School of Professional Psychology. My name is Therese Fowler, and I hope you enjoy my presentation. Addiction, the word addiction, has its roots in the Latin term, which comes from an understanding of being enslaved by and or bound to. Almost 1 in every 10 Americans has an addiction to drugs or alcohol, which is equivalent to 23 million people. This doesn't even account for all of the process addictions that we were working on in this course. And without having proper diagnoses, proper research, the number is likely extremely skewed and much higher. When the word addiction is brought to our attention, most people think of a substance abuse addiction, such as any drug or alcohol use. However, what many people don't realize is there are many addictions that stem from the same brain processes, etc., that react in the same way in our bodies that are equally toxic to us. And some of these addictions are under process addictions, which would include gambling, shopping, sex, food, and more. The case study I've been working on all semester is Sarah. Sarah is a mid-30 Caucasian female who has never been overweight for over 20 years. She's lost and or gained the same 5 to 15 pounds over these years. She binges in secret and eats normally around her friends. She's had numerous relapses with her binges and admits to laxative use for at least 6 years before having an overdose and being hospitalized. She has been finding herself doing things secretively. She's been depressed, irritable. She's had some suicidal despair, and she is now isolating herself from family and friends. She had one long-term relationship that failed due to her eating disorder. And she also was hospitalized during her education and quit after that. So she's had failed relationships and a wasted education. Process addictions, as well as substance addiction, share some commonalities in that they're both neurological diseases. In the beginning, researchers thought that only excessive amounts of alcohol and hard drug use could cause such powerful cravings. It was actually found that process addictions share the same kind of neurological disease that substance addictions find. So in recent studies and research, neuroimaging was shown that pleasurable activities such as sex, eating, shopping, gambling also affect the brain in the same way. It affects the brain through dopamine receptors, and they interact with the glutamate. This is the brain center for reward-related learning and sexual activities such as sex and eating. And this is what's causing these powerful cravings within the brain. The effects on the brain are manifested in 3 distinct and yet connected ways, which are craving the object, loss of control over the addiction, and continuous use despite knowing all of the negative consequences. While studying some of the approaches to take with Sarah, I noted that 2 very distinct treatment approaches would work best for her, and actually I think that they would work better together than separately. I believe that Sarah could learn and benefit a lot from individual therapy as well as group therapy. Both offer her support and understanding of her substance abuse. In individual therapy, I think she would benefit most from cognitive behavioral therapy, which was made by Aaron Beck and Albert Ellis in the 1950s and 1960s. Fairborn published a paper that endorsed cognitive behavioral therapy in an enhanced version for clients with any eating disorder. It is a treatment style that addresses their low self-esteem, mood intolerance, perfectionism, and interpersonal difficulties that can contribute to clients' eating disorders. Further, cognitive behavioral therapy addresses thoughts, feelings, and beliefs with maladaptive coping skills. The difference in individual and group therapy can be somewhat of the cost. As an individual therapy, there is going to be a cost per session versus group therapy, which is normally free. And the general length of commitment is weeks to months with individual therapy, where group therapy, you can come and go as you please. But in group therapy, she could start something like a 12-step program where she can share as she feels comfortable. She can learn from others, and that way she doesn't feel as alone. And she can gain a lot from others who have been through the process and actually learn from others in the various steps of the program how well it does work when you're with others who are struggling with the same type of addiction. There are benefits and limitations to both of these therapeutic modalities, and just to kind of take a look at the advantages or disadvantages and pros and cons, I wrote out a little list here. Group therapy benefits is that you can listen to other stories. It's usually free, as stated before. You can attend whenever you're able, and you can learn that you're not alone. However, there are limitations as well. You may not be as vocal. You may not gain what you need. You could be farther from home. And you can possibly not cover your co-occurring problems if you have any kind of suicidal despair, anxiety, or depression, such as Sarah has. And individual therapy benefits is that you get that one-on-one personalized treatment with your therapist. You will have help for your co-occurring issues, including anxiety, suicidal despair, and depression. And you have weeks of attention that is absolutely personalized to you and your struggle. And then there are, of course, limitations, like it will definitely cost you money unless you can find yourself in a sliding scale and or at a university or somebody who can do the therapy for free. Also, some jobs have like assistants that they can get a couple days worth of therapy for free. But that's unknown to us with the case study Sarah, and if she has the support available to her. So limitation we'll go with is a cost, and she doesn't have the peer support to allow her to know that she's not struggling at this alone. This is why I feel she would benefit from both group therapy and individualized therapy together to give her the most benefits possible. The client and counselor role in cognitive behavioral therapy is that the client will talk and tell their story while the counselor is actively listening. The client will say things, and possibly the counselor would be able to pick up in patterns of behavior. The client can then talk about their feelings and behaviors and thoughts around their addiction, and the counselor can possibly find the client's strengths in the stories and encourage them and teach them. Together, they can set goals, and the counselor will often assign homework for the client to do on days off, and then the homework should be carried out by the client for the next week as they progress in learning how to best go about the addiction together. Two of the assessment tools I used on Sarah included the Columbia Suicide Severity Scale and the Yale Food Addiction Scale. The reasons for this was she was mentioned to have suicidal despair, and it is the gold standard in 2012. It was translated into 103 different languages. There's a pediatric scale available, and it's available online for free. The Yale Food Addiction Scale has 25 questions on a 5-point Likert scale. There is a pediatric assessment available. It is available online for free, and the scoring is available online for free as well. When we look at the paragraph that was given to us about Sarah, we're to make inferences and a preliminary diagnosis. The only problem is we don't have all of the information in order to do so. So what we're going to do is look at two different diagnoses that both make sense, and without further information, we cannot rule either out. The two considerations for Sarah's diagnosis would be binge eating disorder versus bulimia nervosa. In binge eating disorder, there are a few different things that the DSM-5 would state have to be included for this disorder to be a diagnosis. First, the person would need to consume more than the average person in a short duration, and there needs to be loss of control over the eating binge episode. Then the second criteria equals there should be 3 or more co-occurring things happening out of the 5 listed, which are eating rapidly, eating until uncomfortably full, feeling disgusted with the self, eating when not hungry, and eating because of eating alone because of embarrassment about how you're eating or your eating habits. Then the third criteria states there should be distress regarding binge eating. Fourth is that it occurs at minimum 1 time per week for over 3 months. And the last criteria would be that it is not associated with any compensatory methods. What we do know about Sarah is that she used to use laxatives, but it doesn't state whether she's using them currently. And therefore, if there is compensatory mechanisms, as you'll see, bulimia nervosa may be a better diagnosis, preliminary diagnosis, that is. And if she's not using them currently, then she may be suffering from binge eating disorder. That said, bulimia nervosa has also a lack of control over the binge eating episode and more than normal food consumed within a short, discrete time period. The second criteria says that the compensatory measures are present, which could be laxative use, enemas, fasting, excessive exercise, vomiting, and some people use more than one compensatory measure. This also needs to occur minimum once a month for 3 months or more. Self-evaluation needs to be influenced by body shape or image. And the last criteria for bulimia nervosa would be eating patterns are not exclusively during episode or episodes of anorexia nervosa. Therefore, without any further information, we will state there's a possibility of her having either diagnosis. Upon further reflection and questioning, we would be able to tell which of these 2 diagnoses she has, and then we could ask the severity if we knew how often she was having her episodes, how often they were occurring, will give us that severity score. If we were able to come up with a diagnosis for Sarah, we would be able to then find a severity scale within the DSM-5. Eating addictions, both bulimia nervosa and binge eating disorder, have the same severity scale within the DSM-5, so I'm able to make this one slide nice and clear and concise. The severity scales for both these diseases would be mild severity would include 1 to 3 episodes in a week. Moderate severity would be 4 to 7 episodes. Severe severity would be 8 to 13 times a week, and extreme severity would include 14 or more episodes in a week. But at this time, we do not know whether or not Sarah is using compensatory measures, like she used laxatives in the past, or some kind of new compensatory measure, and therefore we cannot give her a diagnosis at this time, nor can we give her a severity scale. More information is needed in order to indicate either a diagnosis or severity for the case study Sarah. As with every single client we see, ethical, legal, and cultural considerations need to be evaluated and looked at on a person-to-person and individual-by-individual, client-by-client basis. Some ethical themes that may arise in a patient such as Sarah with eating addiction may be personal control, willpower, and choice. Some scholars find that if this eating addiction were to be a diagnostic capability, that it would reduce individual blame, and other scholars find that it may reduce personal responsibility. Blame and weight bias are very real ethical themes that can come up when it comes to respect, discrimination, social justice. All topics of interest in blame and weight bias are researched. Some legal implications that can be noted are treating clients under 18. You would need parental approval. And also insurance and billing issues may arise as eating addiction is not a diagnostic capability in the DSM-5 at this time. Cultural considerations are, especially here in America, are that there are external pressures to appear a certain way. And there's emphasis on body weight and shape. Also, eating disorders and eating addictions, like Sarah has, are non-discriminatory. So anyone, any age, any culture, any ethnicity, or sexual orientation could have an eating addiction. Like with all addictions, we need to worry about relapse. That said, we should think about relapse prevention and how to help clients best in the best way we can to prevent any kind of relapses from happening. The mainstay of addictions for over 3 decades has been the RP model, Relapse Prevention by McKay and Marlette, which was done in 1994. It helps you understand the negative emotional state, peer pressure, environmental pressure, physiological factors, and euphoric recall. It addresses behaviors, feelings, and emotions surrounding the addiction, and it points out high-risk situations so the client can learn their patterns and break them. When we think about relapse prevention, what we're really thinking about here is breaking the cycle that they have, breaking the pattern of behavior. It's when a client has an urge to use or eat or go do whatever it is that their addiction may be, gamble, shop, etc. What they need to do is tell on themselves. Have a support system in place, friends, family, loved one, somebody else from a group therapy if you're in that, and tell on yourself. I'm craving and I'm worried I'm going to go ahead and continue to use whatever it is, the coping mechanism that they have and whatever addiction they might be struggling with. So if you tell somebody, it tends to take away the power of the addiction. And so it could work. Another thing that is written here by Melamis 2019 is to go ahead and distract yourself or wait 30 minutes. Color in a book, get some exercise, do something else that you love. And hope that in that time, the craving passes. Also, it's very great if we could teach clients to really celebrate all victories, all little victories, and to only do their recovery one day at a time. Not to look at the big picture, not to look at the past if they've had a relapse, and not look too far into the future either, to just go one day at a time, just control the next 24 hours so that those 24 hours turn into 48 and 72. So they just kind of slow it down because it seems like they can have more control if the time frame is just one day, one step forward, one good choice at a time. And then include lots of relaxation. One thing that is never taught enough is self-care. If we can have our clients just incorporate more time for themselves, things that they love to do, take a bath, walk in the park, go for a jog, read a book, write in a journal, etc. These self-care activities can really make a difference. And so I like that Melamis states to include lots and lots of relaxation as you're going through and changing patterns or behaviors. Thank you for listening to my presentation.